Good morning, everyone. Welcome to Coffee and Cases. I think today's presentation is going to be a really cool presentation. We're just going to start out with the usual reminders. So just a super quick reminder that this is a really safe space. The idea is to create an open forum for people to share, engage, and learn from each other. We have quite a few people who are on the presentation today who are forming part of a panel for discussion. And I think we are really excited to be able to use their knowledge, their experience, and their thought processes to help us do better in the EMS and retrieval settings. We're going to start out today just with a quick introduction of everyone who's joined from the panel. And then we have a really short case presentation just to kind of set the scene. And then what we'd really like to be able to do is get the panel so engaging in some of the thoughts and some of the challenges around the case that is presented. And then we'd love for you guys who are on the call to share your challenges, your thoughts, your experiences, and maybe figure out a way to kind of co-create some thought process and some guardrails for how we could better practice in the critical care and emergency retrieval spaces. So I'm going to just maybe call out names of the people who have joined from our panel, and I'm going to ask everyone to just introduce themselves and to give us a little bit of background as to where you come from, where you're currently practicing, and what your expectations, maybe intentions for this presentation today really are. I'm just going to start at the top of my screen. We'll start out with Julia.
Morning, everyone. I'm Julia Ambler, based in Durban. I'm a doctor practicing in pediatric palliative care for the last 22 years. I run an NGO in Durban called Umduduzi Hospice Care for Children, where we see a lot of neonates. And my expectations for today are really just to listen and learn as much as anyone else. So thank you for having me.
Thank you so much for joining us. Next, we're going to go to Lynn, and we have two people sitting with Lynn.
Morning, everyone. I'm Elmi Fall. I'm also a doctor doing palliative care in private, and then here with Lambano Sanctuary, where Lynn is joining me from today. So I'm a GP doing palliative care, and that's going to be where we focus today. And Lynn has a very wide background. Lynn?
So I'm actually a critical care assistant from a long time ago and now in palliative care. So for the last 24 years, I've been running a children's hospice.
Amazing. Thank you so much for joining. Next on my list is Marina.
I've been working in critical care retrieval space for quite a long time with quite a high volume of neonates that I've seen in my life. So I think Caleb asked me to be here because I'm sometimes really opinionated.
Thank you for joining. Next on my list is Caleb Gage. Caleb? Okay, we'll come back to Caleb in a second. So next on my list is Nikki.
Hi everyone, my name is Nikki Brown. I am a neonatologist working at General Justice Gazinga Hospital, otherwise known as Stanger Hospital, up on the north coast of KZN. And I've also done my diploma in palliative care because of the fact that working in neonates, we have to palliate a lot of our patients. And I'm trying to set up a perinatal palliative care service in KZN at the moment.
Amazing. Thanks for joining. If I've missed any of the presenters that I haven't made presenters just yet, please won't you just send me a message if you have not yet been able to introduce yourself. Caleb, you should be able to unmute at this point. Possibly, Caleb, you might need to just jump off and then jump back on again. Okay, while we figure that out, we're just going to go to our sort of first presenter, who's going to just share a case that was recently managed within our critical care retrieval space in the Rocket Hem space. Relatively difficult case, but kind of a sort of example of the kind of cases that we are starting to see. And I think this is not just in the critical care retrieval spaces, but we're also seeing these patients across the board in EMS, but also in our very peripheral facilities and in facilities where there maybe isn't the resource and maybe always the experience and knowledge to deal with these really sick neonates. So Mikhail, are you happy to? Oh, there we go. Caleb, do you want to go ahead?
Yeah, thanks. Can you hear me?
Yes.
Great, thank you. Yeah, so my name is Caleb. I'm an ECP currently working for City of Johannesburg EMS, and my involvement in this space has been through quite a bit of research looking at integrating EMS and palliative care systems.
Amazing. And Caleb's recently published some articles from his PhD. Go and have a look for them. Mikhail, we're going to jump straight onto your presentation, and then really the idea is an open floor. So please feel free to think about the things deeply and let's share an experience. Mikhail?
Good morning. I'm just going to share the screen quickly. I just want to confirm that you can see the screen.
Yes.
Okay, great. So good morning, everyone. This is a case that happened last year at a periphery hospital here in Limpopo. We were dispatched to a periphery hospital going to Polokwane Provincial Hospital. The call came in as a 2-day-old baby boy born with respiratory distress. These are the vitals that were provided when the call was logged. Heart rate 140, sat 60 on nasal prongs, respiratory rate 44, low birth weight of 1.8, and the ALS on scene stated that the patient was too unstable for transport. So when we arrived to the patient, less than 30 minutes flight, patient was lying in the incubator, IV in situ, free flow and running, being BVM ventilated via size 2 ETT. The patient was said to be born via NVD, required continuous stimulation at birth and ventilation. The patient was then placed on maintenance infusion. CPAP, had continuous hypoxia on CPAP for the past 2 days. ETI was done prior to our arrival, so when the ALS arrived, and then ground ambulance or ICU ambulance was activated. They tried to load the patient, stabilize, and was unsuccessful, and then called for the heli. So when we arrived, we found the patient floppy, unresponsive, pupils dilated, unresponsive as well. We heard an audible leak on the BVM as they were ventilating the baby. The sets on the monitor, as you can see, there was 41, heart rate of 153. We attached our monitors, took over BVM ventilations, as well as added a PEEP valve to the BVM just to try and improve oxygenation. We attached our monitors and we had a SATS variation of 1 to 53. So the SATS was just jumping around 1 to 53. Heart rate was above 150 throughout care. We connected ETCO2, so the tube was in. We confirmed it. We were ventilating. The incubator was on and the baby was home. Patient was still GCS3 and floppy. We then decided to extubate the baby. Extubate the baby, try to pre-oxygenate as best as possible, and then re-intubate without any drugs with a bigger size ETT. BVM with PEEP attached, placed the NG, decompressed the stomach, secured, and then tried to improve perfusion initially with a fluid bolus. Our SATS variation on different limbs, there was more than 3 to 5% difference, but it was difficult to assess because the SATS was continuously jumping and varying from 1 to 53, 1 to 40, instantaneously without anything changing. Initially, we then initiated inotropes attached to the ventilator on PSIMV mode, titrated the settings up to improve oxygenation, and then we switched to PCV mode and then made a phone call to our clinical to discuss magnesium sulfate. After discussion with clinical, we decided once we have a good BP, which initially we did not have. As you can see, BP was not picking up continuously. And then after we titrated the adrenaline up to 0.6 to 0.7 mics per kg per minute, and after the fluid bolus, we had a better blood pressure. It was also dropping and varying, so it was difficult to assess, but we could see that some perfusion did improve. We didn't have sildenafil initially, so our other option was mag sulfate. So we decided to start an infusion, 100 milligram per kg over 20 minutes for the pulmonary hypertension. The SATs still did not improve. I think we were on scene for about an hour and a half or 2 hours. SATs didn't improve. Oxygenation is not improving. Perfusion is borderline, but we titrated the inotropes up and we were not winning on all aspects of oxygenation. We then decided to call the receiving doctor, which is the neonatologist at, I just want to confirm, at Polokwane Provincial, and she stated that the patient had a poor prognosis due to the prolonged hypoxia, minimal response to inotropes and management, and decided for us to initiate palliative care. Initially, we didn't want to give up yet on the patient, and we wanted to transport, and we were eager to transport, and we decided, okay, we're going to give the patient the benefit of the doubt, and we're going to transport with a stable heart rate or a consistent heart rate. And then as soon as we move the baby into the incubator, everything went haywire. Nothing changed. The tube was in, there was good EtCO2, oxygens were full, the airway was suctioned, and we noted instantaneous bradycardia and desaturations. Once we moved the baby back to the hospital incubator, it leveled out, and then we decided, after continuously doing this, that unfortunately the baby is really unstable, and we're going to follow up on what the doctor said on palliative care. The mommy was called in the room and was explained. Obviously, there was a bit of a language barrier, so we couldn't do that. The hospital team did that. The baby was placed again on CPAP, and palliative care was initiated by the hospital. We stood down for the case and then debriefed afterwards.
Thanks, Mikhail. I think a really nice summary of the case, and sort of really a good example of the kind of cases that are popping up over and over. So maybe we can just go to the panel. I think maybe just some thoughts, initial thoughts. What have you sort of pulled out from the data, and what are some of the talking points that we maybe need to cover in order to make sure that we cover all the things related to the challenge of this case and palliative care in general for a patient like this? I don't know if there's anyone who wants to start.
I'll start. So this is Julia. Bearing in mind, I'm not involved in emergency care at all. So everything I say comes from a place of care and curiosity, because this is not my comfort zone. But I think what I was really struck by is the decision not to take the advice of the clinician that said move to palliative care. And I think I was really struck by that, because I think it speaks to the fact of when you're actually on the front line, how difficult that must be. It's so easy for me as a strictly palliative care provider. in a hospital space to recognize the need for palliative care and say, right, okay, this is a decision that's been made and let's move swiftly on. But I don't know that I've ever given enough thought of how difficult it is for you guys that have actually spent an hour and a half or 2 hours with a child or a baby, trying to resuscitate, trying to give them established, and I love that word, give them the benefit of the doubt, when actually when you review all that clinical data, it was probably quite obvious that this child was going to have a very poor outcome, but retrospect is very easy, isn't it? So I think that was the first thing I was struck by. And then just not, I don't think I've ever really thought about the difficulty in communication that you would have had with the mom and trying to explain what had happened. And you've actually spent the most time out of anyone with that baby in this particular scenario. So, gosh, I think I've learned something today about how difficult that decision is on the front line. So that's all I have to say for the moment.
Julia, thanks for that. So this is actually something that we've been coming up against in the last little while around there's a disconnect between the decision to palliate and then the actions that one has to take in order to get that right. And the absolute disconnect, especially for the emergency care provider, where all the training is focused on save, save, save. And there really is a very minimal training and thought process and sort of exploration of the concept of rather not saving, but making the space more comfortable and sort of pulling back in life-saving care, but maximizing sort of comfort care. And I think what you said so nicely is that at the front line, you can make the decision. The decision is really easy. It's super clear that this patient is really not going to do well. But the actions that you have to take to be able to get that right are really tough. So I'd love to go actually back to Mikhail, and just also get an idea from him in terms of what are the barriers to actually providing those actions in that peripheral hospital with the kind of support that's available in the facility. Mikhail?
Hi, so yeah, I definitely agree with the doctor there in retrospect. But at that moment, we were there, adrenaline was high. We also had to, in order for me to call the receiving doctor, I had to step out of the facility and make the phone call and be on the phone for like 2 to 5 minutes just to discuss things because there was no signal. The issues with bringing the mommy in, she doesn't speak English, so only the nurses and the doctor that was present could basically translate what we're trying to do and tell her, but that was also a huge barrier for us. There was also a disconnect with us because I think I called Caleb on this one, and we were like, okay, we're going to palliate, but the referring doctor was also pushing the patient out, and only eventually, once we all took a step out of the facility to make the phone call together on speaker, that's when she actually realized, okay, now we have to palliate. So that's basically it from our side.
Awesome. I see there's a hand up, Nikki.
Yeah, thanks. So I have to say I've been in this situation many times as the receiving doctor and the referring doctor, and I really empathize with you because you obviously, as you say, you come in this you kind of the in-between between the receiving and the referring doctor. I do find that we a lot of the time the communication between the receiving and the referring doctor is not great. And we, like say I'm a neonatologist accepting a patient, I often rely a lot on our retrieval services and the paramedics on the ground to give me a true picture of what the patient looks like. Because even though I think it's maybe done with the best of intentions, patients are often painted in a much nicer light than what's actually really happening. And so there have been quite a few situations where somebody phones me and they said, we've come to collect, to retrieve this patient, and this is how the patient looks, and they really aren't stable for transfer. And so I empathize with you for having to be that in-between person, because it maybe from what it sounds like, the patient was probably never stable enough for transport in the first place, should have been stabilized at base, and if ever improved to a point of transfer, then that's when you guys need to come in. So and then again, you know, for you to have to speak to a mother that you've now never met, I would have hoped that the referring doctor or staff that are working at that hospital had some kind of relationship with that mother, so they could have explained, you know, what was going on. And then again, over the years, I've also realized that sometimes taking patients away from mothers and away from, when just to literally to go die in another hospital, is often not ideal, and it's cost, it's finance of trying to get a baby's body back. Whereas if palliative care is done properly, and I think this is also where there's an issue, is that it often isn't, giving this baby and this mom time together, where the baby could have died in the mom's arms, she could have held him, he could have been given analgesia and palliated, it would have ended up being a beautiful death, as opposed to, you know, just dying in another hospital, having a whole lot of procedures done. So there's so many things to consider, but again, it's very hard when you're the one that's looking the mom in the eye and looking at the baby. But it does sound like this baby probably wouldn't have been stable for transport even from the beginning. So I don't really have an answer, but just to say that I empathize with you, and we really do appreciate the fact that we get sometimes a lot more information from the retrieval team than we do from the referring doctors. But yeah.
Thanks, Nikki. We're going to go to Morena and then Lynn and Elmi.
Some of what I wanted to say, Nikki already said now, especially in the HENS environment where you cannot take the parent with for the most part.
Yeah, it's a real big challenge. I think so. Some of the times we are able to take the parent with, but you're also then only able to take one parent, and then that poor parent is in an unknown, uncomfortable, unfamiliar environment with no family support. And it really does add up into the stresses of that poor mom who's already having a very, very stressful day. Next, we're going to go to Lynn and Elmi.
So it's Lynn speaking. As a paramedic, I empathize with you guys because you're there, you're on an emergency call, and your function is to make sure that the patient arrives alive at the new facility. So it's a very difficult thing when you've called, you all adrenaline running, it's a difficult patient, and then for you to stand down is incredibly difficult. So I do empathize with you guys. But what I wanted to say is from going from paramedic to palliative care is kind of not in our psyche, because we've become emergency practitioners for a reason. And it's the same with when you've got doctors in ICUs, when you've got doctors in casualties, we all geared to go, and to save lives. So we work with Dr. Ambler and Patch and APCC in the palliative care setting, and we're really trying to push for people to be trained, for doctors to be trained, and now paramedics. It is something that has been flagged that we do need to include paramedics because of the kind of cases that you're getting. So all I wanted to say is that we really need to find a way to educate you guys, because education is key, that you're comfortable enough in your own skin to have an emergency talk as well as a palliative care talk, and you're able to stand down in comfort, because then you're able to understand what palliative care is about, and you can explain to mom. And yes, I know you're using a translator in most cases, but you at least are more comfortable within yourselves to have this case and don't feel so out of your zone.
I completely agree with Lynn in the training aspect, and I actually also wanted to speak about that. And some of the barriers, Caleb, you were you were asking what are some of the barriers, and I think in that situation where adrenaline is high, it's difficult to have these types of conversations with families about, do we stop this intensive, invasive, life-prolonging treatment? And we can go into the ethical guidelines about when is it acceptable to withhold or withdraw care. But in practical settings, those conversations take time. Just yesterday and the day before, I was sitting with a family of a neonate that we were considering withdrawing care. And my counseling over the 2 days for that family was the better part of 5 hours. So for you guys as the HEMS people to now all of a sudden go from we're transporting this baby to save his life to saying, okay, but now we are palliating, do you have the skills? Do the mostly junior doctors in the base hospitals have the skills to have those conversations? Because you just can't go from askis, mama, things didn't work out, change of plan, sorry. You can't do that. It's the way I think 2 things stand out for me or 3 things is that you need time to have these conversations. And if you don't have the tools as to how to address this, to explain to that mom why we're doing what we're doing, it's going to be very, very difficult for you guys in that setting to have these conversations. And you also don't have the mandate to just change the goals of care all by yourself. So you need to do it with either the referring team or the referral team, but someone needs to sit in a calm way with lots of time and explain to the parents, and this is another thing that was said, to say, we weren't ready to give up on the baby. But to explain to that parent and the doctor and the referral team, we're not giving up on the baby. We are redirecting our care, because you will never, ever withdraw care without instituting palliative care. But if you don't know how to do that, how are you going to do it? Then it's going to feel like you're giving up. But to explain to the family, I'm not giving up. I'm just focusing now on dignity and kindness instead of the thing that we tried and it didn't work. So that's the thing. You need time and you need the skills. But then also the challenge, I think, that stood out for me, and I can't really talk about it because I wasn't part of the discussion, but I'm just wondering, the referring or the person on the receiving end of that consultation, I always get confused with the wording, when they said, no, we have to change now to palliative care, did that specialist advise the team at base how to do that? Or are we now putting the baby back in its crib and that's it? Now we're waiting for him to die, because palliative care is not waiting for you to die. It's making sure that you live a good life until you die, even if it is just 5 minutes. Did they explain to the junior doctors at base how to do that? How to give the pain control that Nikki was talking about? How to make sure that we can alleviate this baby's dyspnea and shortness of breath? How can we prepare the mom? Mom, this is happening now. You might see this happening now, and we're expecting it to happen, and it's not nice, but it is part of the process. And those things take time and compassion and a lot of patience. And if you are in a situation with the adrenaline pumping, it's not the way you were trained, and now you're expected to do something and you don't have a clue how to do it, it's fighting an uphill battle all the way. So going back to what Lynn said, the training. How can you do something if you don't have the tools to do it?
Almi, I just want to really highlight, if I can, the the difference between the way that you're speaking and the way that the emergency care team speak, just in terms of speed. And like just that sort of speed difference is immediately obvious in the way that you need to engage with these patients. We are so good at getting things done fast and ADHD excitement, and that's not the way to do it when we're transitioning into a palliative space. And I just love that sort of difference between the way that you were speaking and the way that Mikhail and myself kind of speak. Your whole setup is around how do we create the time for the mom and for the family and for the patient. I really love that.
Yeah, it's something you have to train yourself. And
Yeah.
I mean, I think when any of us doing palliative care just came into the field, it was something that you need to slow down time on their behalf. You need to read the room. You need to allow them space. And you need to be intentional with those things, because otherwise you will go back into your Energizer Bunny mode. But yeah, it takes practice, and you see it with the families as well, because they reflect off you. So it's a skill, but it's exactly that I have been saying. If you don't know that is actually part of the toolbox that you need, then it's going to be difficult. No one can blame anyone for anything if they don't have the knowledge. So yeah.
Thank you for that. We're going to go to Caleb.
Yeah, thanks. Just to build on what was being said, because I think it's a very important point, especially from a conceptual point of view. I think this case highlights potentially one of the misconceptions that we often have about what palliative care is. So palliative care is definitely not giving up. It's certainly not withdrawing care. One of the ways I've always heard it said is that it might be acceptable to withdraw treatment in some cases, but it's never acceptable to withdraw care. And so, one of the common misconceptions I found in the emergency medicine space is that palliative care is sort of the last resort, that, once we've given up on our curative treatment, then we institute palliative care. Whereas actually that's not really the case. Palliative care works at its best alongside curative care. And so the earlier that you can identify some palliative type needs and institute palliative care and bring in those principles, the better. And I think that's important to understand, because even in the neonates then that we transport that are stable enough to move, perhaps they also, though, have some palliative needs, and we can implement palliative care principles then as well. It doesn't necessarily just need to be in the end of life. And then another big question that this kind of case raises, I think, for us in the EMS side of things is, what exactly is the EMS role in terms of palliative care? Because my suggestion, and this is, perhaps we can discuss this at length, but my suggestion is that EMS providers are not in the place, and shouldn't be in the place, to make these decisions themselves. So I should never go to a case, especially in a HEMS environment, and say, oh, I think this is palliative, so we're going to withdraw care. Palliative care is by definition a team approach, so it should never be an individual provider. So my suggestion is that the EMS approach, based on findings that we've had from interviewing palliative care providers, EMS providers, is that the best approach for EMS is, first of all, to be able to identify palliative needs and identify what cases might fit into these categories, flag that, and then link that patient with the appropriate type of care. So where palliative care services or providers are available, try and get some consult from them, link with them. And then maybe those people can actually give some of that advice that was potentially missing in this case, to say, okay, here is how you provide some analgesia in this situation. Here are the principles that you should keep in mind. So I think it's very important that we discuss the actual role of EMS in these kind of cases before we start doing things in isolation.
Such a good point. And I think we must definitely come back to that. It is one of the things we do want to make sure we kind of leave with an idea of how we're going to do this after this discussion. But let's go to Julia and then Marina, and then I will open up for some of the hands that are up in the audience as well.
Gosh, yes, I don't want to sort of dominate with the panel, but just a couple of things that have come to mind. Following on from Elmi, I'm often on the other end where a child has been retrieved and is now at the hospital, and now things are going wrong, or they're going right, and the child is going to survive. And there are a few things that can happen, to a child like this that does survive, is the long-term impact on that family of a child that has significantly got special needs is really, really hard. So I just want to put that in there, that I'm not saying we withdraw and that on the scene you just say stop because this family might suffer in the future, but perhaps it might help. I know you can't think of that in the moment, but when somebody has suggested palliative care for a patient, is trying to pull yourself out for a second to think, actually, if I stop now, a lot of drama could be saved, because those families in the future, when we have gone too far to save a child, sometimes the outcome is not good and the child is still alive but barely living, and there's a whole family holding their breath because this child is so impaired. At the same time, on that whole empathy thing, that slowing down and giving that space, what we often hear from families that have been bereaved is, gosh, the paramedics were amazing. They did everything they could. And that is a memory that you can't take away from them. The fact that you guys tried so hard to save their precious child's life. And if there is a slowing down, and if that is all done with empathy after the fact, that memory of how hard people tried and how much their child meant to someone else really does aid in their healing and in their grieving. So just two thoughts to maybe help in the kind of how do we move to palliative care. And then just lastly, around the role of palliative care and EMS, it is absolutely essential we have in this conversation. The number of times that you guys get called to palliative cases, perhaps at home, not on the retrieval side, but I mean, you guys are the ones who get called when a patient is suffering in the middle of the night, even if nothing can be done to change the underlying diagnosis. So we really do need to be looking at how do we work together? How do we make sure that when a child has got an advanced care plan? I've recently had a child at home who was very short of breath, and the parents panicked, even though everything was in place to support them. The paramedics got there and also panicked and tried to put up an IV line and tried to give steroids and tried to do all sorts of things, but the child was dying of a metastatic lung cancer. And none of that helped the paramedics, none of that helped the child, none of that helped the parents. So, yeah, we need to be working together better, and I'm looking forward to the outcome of this. Thank you.
Amazing. Thanks, Julia. Marina, and then we're going to head down to Mike.
Caleb, not you, Caleb, I think Caleb Gage mentioned the discussion around the group and the team discussion. And I want to say that is something that is hugely missing in the EMS, in the retrieval space. And I think it's up to us to find a way to make that team dynamic better, because what happens in our space is we do consult. You on your own, like it was mentioned even, you're not the one that just by yourself goes, okay, we're done here. You're the one that thinks it. And then, but what normally happens is you speak to the receiving doctor. That conversation ends with them saying, no, the show is not stable, I'm no longer accepted. That's the end of the phone call. And then I was even wondering when he was doing the case presentation and he said, we decided on palliation and we put the baby back on NCPAP. And is the outcome that we de-escalate our care, we put the baby back on NCPAP and we leave because we have to leave. And then at the hospital, they just wait for that baby to slowly die. Or, like you mentioned so validly, that they still give that baby the care that baby deserves to die as painless and sufferless as possible. But that discussion, the how do we go about the next steps when we withdraw care, I think it's hugely missing in our EMS space. We simply we speak to your senior doctor, you get the answer that, okay, don't come in one no longer accepting, and then you stand there sort of with, okay, well, you withdraw our care. And so the next step, what do we do next? That is what we need to fix in our space to make the patient and the family experience better when we make these decisions.
Yeah, and I think also empowering the more junior doctor in the very peripheral area where, okay, we're going to do palliative care and we're going to leave, but there's still that super junior doctor in the faraway place without any support, now suddenly having to manage this really difficult scenario without anyone to assist them because help has said, no, you can't send the baby. And so sometimes these situations are better in the more central spaces where there is help. I do want to just quickly go back to Elmi, and then we're going to go to Mike and Michaela in the audience.
Thanks, Caleb. I want to add on to what Julia said. And I don't have an answer for the whole dilemma about what do you guys as the HEMS people in the EMS, and it's not your call to make and all of those things. I don't have solutions for that. I don't think the purpose of the talk is to find solutions, but just to start working towards finding them. But I think it's important for everyone, the paramedics, the nurses, the speech therapists, the doctors, the counselors, the social workers, everyone, to realize that everything you do and how you do it, and that's sometimes more important, will influence on the grieving process of the family. And even if it is, dear my God, and now we're doing this and now we're doing that, the way you treat that family, what Julia said is where the families come back and say they're so grateful for the paramedics because they did everything. That will positively impact on that family's grieving process. Whereas if it's this whole well, we can't do anything, so now the doctor walks out the ward and they're not counseling the parents and they're not adequately preparing them for what's what's coming next, sorry. It goes back to, in that moment, in that chaotic moment, to just hit pause and ask yourself, how can I handle this situation that will give this child and give this family more dignity, to give them the dignity and the kindness that they deserve in that moment? Because I think sometimes we forget that, and you start off by doing all the things that you did in your presentation case because you weren't sure of the outcome, but then it became clear. So then when you then turn around and change direction and change gears, just to be aware of that. How can I improve the dignity of this child in this moment? Because everything I do now, it's not ending when this child passes away. It's influencing the family's grief. And it's just a thought, it doesn't end with the death of the child. It goes beyond that.
Sure, that is a perspective I don't think that that we always catch on to with the EMS spaces. Mike. Mike? Otherwise, we'll come back to Mike. Let's try Michaela.
Hello, everyone. Thank you so much for bringing up this topic. It's quite close to my heart, as me and my partner recently had a case where we'd kind of thought to ourselves, why are we transferring this child across the country where he has no family or anything like that? And when we started talking about it, the receiving doctor had said, okay, let's discuss it, actually take the patient back to referring. And that's one of my barriers that I've picked up is the referring was not on the same page. So how do we manage that as a transferring team when you take the patient back to have that discussion? Because we'd had a talk with our family and said, look, we done everything, we're still doing everything, but his prognosis is very poor. And then when we got to the hospital, the doctors were happy. They're like, there is a pulse and we're going to try transfer him again. So how do we manage the kind of not being on the same page?
A really good question. I think Caleb's got his hand up.
Yeah, I'll take a stab at that one. Thanks, Michaela. It's a good question, and it is one of the barriers that all of us in the EMS side of things often experience. And I think, to be honest, from what I hear of the way that just briefly you handled that situation, I think you've already started doing the right thing there. Because one of the massive barriers is just the complete lack of awareness amongst emergency medicine of a different type of approach to care. We're just simply not aware that there is this thing called palliative care, and we just want to intervene. We're happy when there is a pulse. So I've found with a couple of cases myself where just the fact that I've been able to identify that, hey, the prognosis is not great here, perhaps this patient would benefit from an alternative approach to care rather than a curative one in isolation. And then I sort of have a look to see, just to sort of test the waters with the family members and see, and the patient, if they're able to, and see what is their current understanding of what is going on. And I've often found that no one has even explained to them that there could be an alternative approach. And sometimes when you explain that alternative approach to them, they are incredibly grateful for that. And they'll tell you, no one else ever told me about this. I thought we just have to listen to the emergency doctors and go into ICU all the time, you know. So just being able to identify it and have that conversation is so important. And I think that this relates to kind of what we were talking about previously as well, in terms of withdrawing treatment and so on. It's funny because you can even tell in this conversation, the way that we talk about it, we talk about we as the emergency or the healthcare providers. We make the decision to withdraw care. We withdraw this, we do this. But if we are actually looking at a truly person-centered approach to care, it shouldn't necessarily be me making the decision to withdraw as the healthcare provider. Where is the family at? Is that their decision? Is that what they want to be done? Or does the patient and family member want us to continue to do as much as we can on the curative side of things? So we need to have that conversation with them as well. So going back to the example of the neonate, is it our decision as healthcare providers to withdraw care? We don't own that baby. That's the family's baby. So we always need to remember to have that conversation first. You know, that's a big mindset shift for us in the EMS, is that we're so used to going into situations and taking control. Whereas in the palliative situations, we should be looking to give as much control to the family and patient as possible, and sort of relinquish some of our control. So just some thoughts there, and I hope that in some ways answers the question.
Oh, that's a powerful answer. There's a part at the end there where you said we should be looking to give as much control as possible to the family. That just really hit home for me. I know Mike has been really struggling to get his hand up. So maybe if we can go to Mike, and then we have Cindy, and then Heather.
Thanks, Caleb. Hi, morning, everybody. Yeah, just reflecting back on what's been said so far, and some comments that I wrote down during the listening to the case. And you know, empathy is care and treatment, and I think between the two schools of medicine, emergency or CCR and palliative, we kind of, you know, conflate and get the words mixed up between care and treatment. There is no difference, because both of them pushing towards the same outcome. And both of those cares and treatment and or routes of managing the patient form part of the same treatment line, and they're not separate. They are the same. They both work hand in hand and side by side. And it should be the team approach is critical, because that's also been reflected that EMS sometimes thinks we work as a retrieval team, not part of the wider team. And that also comes back down to training, that we need to learn we all on one path, and that treatment, care, it's the same thing. And empathy should be a part even of the rush of emergency medicine, because we forget about that the person we're working with is actually at that moment a living, breathing entity, that no matter what state they are in, they would desire of our empathy, and no matter how much time they have left in this life, they want our empathy, even if it is a unresponsive patient or a patient who is spiraling down. They want, demand, and deserve our empathy. And I don't think this is a conversation we have often enough in emergency medicine. I'm still fortunate enough to teach ITLS, and I try to drive the thinking in the ITLS environment as well, is that we need to learn to have conversations about when do we start, when do we decide to change the care from the rush of emergency medicine to moving into more of a end-of-life medicine. And then also have the discussion, the conversation is, are we going to be starting with emergency medicine or starting immediately with end-of-life care? And I don't think we have those conversations enough, and I don't think we incorporating it into our training to give people the courage to be able to make these calls in a team environment, even outside of a hospital, in a pre-hospital setting. And I really think that's an important element of medicine that we have to look at, to make the whole scope of care far more well-rounded at that point in time, in terms of the whole treatment paradigm that we've been discussing, which is the care, the empathy, and the collective working together. Thank you.
Thanks, Mike. Some really awesome points there. We're going to go to Cindy. Sorry,
Thanks.
Cindy. Yeah.
No problem. Thanks, Caleb. It's actually just two observations and comments. So I'm an ALS paramedic working in a hospital environment as a transplant coordinator. So essentially what we do is palliation as well. And not every patient turns to a donor. Some of them we have to abort organ retrieval or resuscitation and allow the patient to pass. I think it was Lynn who said it about pace, and you made the comment, slowing it down, slowing the whole scenario down. It's about cadence and moving from the panic of moving the patient or treating the patient to calming it down, allowing the family time to say their goodbyes and be with their loved one. And the second comment is that of one of our doctors involved in transplantation, Professor Thompson, describes what we do as providing a good death. And I think if there's anything we should have in our back of our minds is we can't save them all, but we can give them a good death. Thanks, Caleb.
Thanks, Cindy. We're going to go to Heather next.
Hi, everybody. Yeah, I just a comment that I sort of noticed over my years, both in the receiving hospital situation and in the retrieval situation, which also goes back to education and discussions. The concept of we are moving the patient, be it adult, peds, neonate, the concept from the referring hospital a lot of the time gets sold on the fact that when you get to the next hospital or the receiving hospital, that they will miraculously, make this person survive and sort of walk out the hospital. Which then goes back in my eyes. I've had a lot of people, we've arrived at the patient and oh yes, we're going to South Africa because you can save my patient. It's just an observation that I've made along the years of my both in hospital and retrieving.
Sort of this concept of a false hope, just by moving the patient, things will be better on the other side.
Absolutely. And in my case with the international patients, a lot of the time, like somebody said, you've got this person, they don't speak English, they are stranded at a hospital with this huge hope of, everything's going to be fine, we're going to go home with our loved one. And it's not actually the case. And a lot of the time, I mean, you're all seasoned practitioners, and you can almost see from the get-go where this is going to end up.
Yeah. Okay, we're gonna go to Moira next.
Good morning, guys. So I'm also an ALS paramedic now, and I'm listening to this conversation. It really hits home, especially where there's a kid involved. Né? So my train of thought is when there is trauma involved, the patient goes quick. When there's illness involved, the patient tends to suffer. That's what my train of thought is. And the last part of life, the families would love to spend with their loved one. We don't know when we're leaving. And a lot of I've listened to the conversations. People have hope once they see a doctor. People have hope once they see an EMS practitioner. And your approach to that family, sometimes we are so busy trying to save that person. And I'm talking now in illness, when there is no hope left. We will always try to give the best and the last, being it on the road, being it in hospital. I listen to the scenario. It's really touching. It's really touching. I'm one of them. I fight. I'm like a dog that don't give up a bone. I will try my best. But yes, there's a lot of us that try to give our best. And if you sit and speak to the mothers, they really, really appreciate when you show that you are a human being, a mother or a father, an aunt, a sister, or a brother. You also do have compassion. And sometimes it comes down to the train of thought from the doctors as well. Yes, they're overstressed. And they are young as well. Sometimes they're a little bit inexperienced. So that's where EMS comes in. Sometimes we got a longer hand in the service, and we've dealt with many of similar cases. So yes, you're not an island. You're not an island. If you are in the practice, we will work as a team. Being a doctor, being a nurse, that's all I have to say.
Thanks, Moira. We're gonna go to Tilani.
Hi everyone. Thanks, Caleb, for the opportunity. I don't have any questions, but it's more of a comment regarding palliative care, and I'm happy to hear that such discussions are happening. And when we also had an episode on the Para podcast where we spoke about palliative care and even made reference to some of the work that Caleb Gage has done. Now, you can't talk about palliative care and not think about ethics. And I know for a fact that most paramedics, when they graduate, they sort of recite the paramedic oath, or even the doctors, the Hippocratic oath. And when we make that oath, it's a conscious decision to say we are there to do what's right for the patient. Now, when you look at what is the Hippocratic oath, what is the paramedic oath, it looks deep into the ethics, where it speaks about the core elements of ethics, the beneficence, the non-maleficence, and justice to the patient. So whereby we first do not harm to the patient and we aim to benefit the patient, but also we provide equal access and fair chance to the patient. Now, if you think about the case that was presented by the paramedic, is that in all essence, what they tried is to apply the core ethical principles. And if I was the medic in that case, although I would be stressed, but at the end of the day, when I go home, reflect on what have I done for the patient. Did I act in the best interest of the patient? Yes. Did I provide the best treatment for the patient? And what was the outcome of the patient? And in certain times, there's really much that we cannot do for the patients. And yeah, that's it from my side. That's the comment.
Amazing. Thanks for that comment. I think that is the intention for everyone, is to go home knowing they've done what they needed to, but also what is best. Gilbert.
Yes, Caleb, thank you very much for the opportunity and really insightful conversation. What I wanted to ask, especially to the panel, because based on everybody, we are clear that we are always geared up on resuscitating the patient and treating the patient. Can they maybe give us some advice on when you arrive on scene, what are the trigger points that we can start thinking palliative care when we get there and initiate the conversation with the team? So are there any maybe specific things around that they can give us advice, like when you get on, when you at the bedside of the patient and you're looking at 1 to 3, start thinking palliative care, because we always just start thinking resuscitation. So maybe if we can get maybe some advices around that, so that we can also start shifting our mind and start looking at a patient both for treatment and for palliative at the same time. And I wanted to also ask if, because it sounds like most of the palliative care, it's always subjective. It's somebody looking at a patient and saying, maybe the prognosis is not good, let's go for palliative. But are there also other objective things that we can consider? Or how does it normally work? Do they maybe look at the patient's vitals over a period of time and say, based on this, we don't think this patient has a good prognosis, we should think palliative? How does it normally work? And also, last thing I wanted to find out is the patient's family always required to give consent, or can palliative care be initiated without anybody giving consent on it?
Sure, Gilbert, 3 really good questions. Almi has put her hand up to start the answer, and then we'll go to Nikki.
Thanks, Caleb. So there's a very good article from the Royal College of Pediatrics and Child Health about when is it ethically allowable. And I think Nikki is probably better educated on this than I am, to withhold or withdraw life-sustaining treatment. And they basically look at 3 categories, which they then say life is limited in quality, life is limited in quantity, or informed competent refusal of treatment. And that is now specifically by an older child who has a say. And there's a lot of ethics about, what if I'm saying life is limited in quality, who decides what is an acceptable quality of life? I might think one thing as a mom, but my sick child who has to live in that body, if he could tell me, would he feel the same? So what literature refers to then is those 3 big categories. And with limited in quantity of life, they specifically talk about brain death. They talk about imminent death, where despite treatment, the child is physiologically deteriorating, and continued treatment may delay death, but it can never restore life or health. And if you think that our purpose in medicine is to alleviate suffering, restore health, and sustain life, are what we're doing restoring health, or is it postponing death and prolonging and contributing to suffering? And then the next one is inevitable demise, where maybe the death might not occur within the next few minutes or hours, but it will occur in the next maybe days or weeks. And you can maybe extend the life if you continue with the treatment, but there might be very little benefit for the child. So that's what they specifically name under life is limited in quantity. And then life is limited in quality. The article speaks of if the burden of treatment is too high, the burden of the underlying disease is too high, or there is lack of ability to derive benefit. So there's a lot of ethics that you can do, reading that you can do on this. But I want to touch on one thing in that question. And this is a quote from this article, and it says, "The professional duty to preserve life is not an absolute one that applies at all costs. Treatment should only be provided where they are in the child's best interest." Again, who decides what's the best interest, But yeah, there's a lot. There is some writing that you can look into, but it's basically, according to the Royal College, those are your three categories. Life is limited in quality, in quantity, or refusal of treatment. So it's a good place to start when thinking about these things. But maybe Nikki, you can carry on with this.
Thanks so much. I feel like you answered that really well. I don't have much to add in terms of how to make that decision. And it's something, and I have to just say that it's not easy, because every day we are having to make decisions like this, and children always surprise us. So that always just complicates matters. But I think there's going to be definitely cases where it will be very obvious that the decision needs to be, or the plan needs to be, redirected to palliative care. So I will just also speak to the permission from the parents. You don't need permission from parents to redirect care. You have the right to withdraw or withhold life-sustaining treatments as a healthcare provider, as long as it's within the child's best interests. And obviously, like what we say is to make it easier on yourself. Obviously, it's not a decision that you should make on your own. So a team decision is obviously the best way to go. And then good documentation, and then you inform the parents of that. The problem is if you ask a parent to make that choice, to say, can we stop active or life-sustaining interventions, they have to live with that decision. And it's not one that they don't have the medical knowledge necessarily behind them to make an informed decision. So no, you don't need the consent of the parents, but it is always a good idea to have more than one healthcare provider making that decision and ensuring a good documentation. And then you can tell the parents that this is the decision that's been made and it's in the best interests of the patient.
Awesome. Thanks, Nikki. And Gilbert, did both of those answer your question, or is there anything left that you still wanted to have answered?
100%.
Okay, amazing. Thanks,
No,
Gilbert.
it was answered. Thank you.
Okay, we're going to go to Dave.
Thanks so much, Caleb. Sorry, if you don't mind, I'm going to have two issues. One was why I had my hand up the first time. The second one is to speak a little bit to Gilbert. The previous two speakers, Hazenex and then Lynn, that the article you say is, all of us should be reading that. So those are excellent points. But I think for me, Gilbert, you asking your HEMS provider, you arrive on the scene, you're in the coalface, and you need to now make these decisions. And I think the total answer there is it depends. There's so many depend factors. And the first depend factor is how much information do you have on hand? So that comes into our systems. And our systems, when it comes to pre-hospital emergency medicine, is how much information is given, how much telephonic advice, how much telephonic preparedness has been given to the receiving, the referring, as well as the team or the crew arriving on scene. And what I mean by that is, if you know you're going to a potentially hopeless case, or I use the word hopeless in obviously in inverted commas, then there's a very different approach and perhaps a preparation that could have occurred before the team arrives there. If you're arriving on a scene where you have absolutely no idea as to whether you've got a good outcome, a bad outcome, and you're having to make decisions with very little information on hand, that changes things. And it changes potentially even the decision on palliation. And so that's why I say this, that the question is you've given an incredibly broad situational dependence question, because I think the important thing there for me also is, if you're going to make a decision that you're going to be part of a palliation process, and you, being those attending practitioners, are guiding and going down that road because it essentially hasn't been discussed, or that option hasn't been ventured by the referring institution, then you committed. And when I mean committed, you committed in terms of time with that patient, that parent. In other words, you shut your machine down, and if you're going to be there for the rest of the day to see this through, then that's what you're going to have to do. So I think it's also very important to understand that if you're going to make this decision, you can't then jump in the helicopter and fly back and leave the rest of the potential withdrawal or withholding or process to the referring institution. So it becomes very difficult, and I think the bottom line boils down to communication pre-scene, on scene, after scene. And that's why I think we've really come a long way in our systems between our different institutions in trying to build networks and trying to like having Caleb as your consultant to discuss things pre, post, during, to try and make these processes not as shockable to a family when you arrive there and you say, but actually there's no hope here, let's palliate. So that's just a few points that I wanted to make. But why I put my hand up, Caleb, was just to speak to. So it is a slight tangent, and you're more than welcome to stop me if I am not appropriate. But many of you know about this burns patient that it's an 11-year-old. So I'm not talking about neonatal right now. That was in Polokwane, that was transferred to us in Johannesburg, and subsequently is demised. And I think the news brought in the politics side to it, but it's just this has been ringing in my head after this discussion that we've been having about how our systems need so much more polishing, because this was a palliative case, and I think the effect that I'm dealing with is what we haven't necessarily mentioned. We spoke about practitioners, doctors, palliative care practitioners, you guys as the EMS crew. But I've got a passion about nursing staff, and I believe that our entire system works around nursing staff. If we didn't have those, pre-hospital doesn't really make a difference, and in-hospital doesn't really make a difference to a doctor qualification if your nurses aren't looked after and aren't looked after incredibly carefully. And I bring it down to this particular case, and just to highlight what happened. This child was burnt. It was referred as about a 50% with inhalation burn from Zanin. On one night, a trauma surgeon accepted the patient. There was an issue with the transfer, and the next day, so then this child was sent from Zanin. I'm not sure who the service providers were in terms of our HEM service. I apologize, but I'm not sure if it was you guys. Okay, but went through to Polokwane to then be airlifted through to Johannesburg. In Polokwane, he was on maximum therapy and was deemed that we were basically going to be transferring the place of death. That was now trauma surgeon number 2 was consulted, and at that stage it was now 55% burn with inhalation, and it was decided that we're changing the place of death, which has been brought up earlier on in this discussion, and that's not a good idea. So let's rather palliate the child properly, which, as you know, in burns patients, there are some good pain protocols, etc. And there was then a decision to transfer back to Zanin, where his hometown was, and do the palliation there. Now, day 3 arrives, he's gone back to Zanin, and a new medical crew has taken over. They've now resuscitated the child and feel that he is for an attempt at advanced care. So the third trauma surgeon in Johannesburg decides to accept the patient. He arrives with us with an 80% burn and inhalation 3 days after no intervention has been done. I think the painting, the writings on the wall here. And my point here is the amount of resources, the amount of heartache and pain for this particular family being from Zanin to now Johannesburg, and 72 hours of 120% bedside care, throwing every single therapy there is known in critical care, bar extracorporeal life support, to this child and the child demise subsequently. And the effect that this has had on the nursing staff is actually quite profound. And I think that's the one area, sorry, so the tangent of my conversation here is many of these places in our districts and in our peripheral centers have got nurses and many times nurses with the most incredible amount of passion and compassion. And I don't know that we always include them when we get there from the bigger centers, from the resource rich areas and all the rest of it. Do we involve the nurses on these journeys? And particularly if you're going to be doing palliation, as you said, we're not coming out with exactly the route of how we do it in this conversation, but I think that's an area that if we are going to try and do things, we need to involve those people. It's not just the pre-hospital, it's not just the doctor consultants and our palliative care consultants, which hopefully now will be on tap to phone when our pre-hospital practitioners need. But it's the nursing staff, and I think that needs to be addressed and highlighted in a really large way.
Dave, I'm so glad you brought up this case. It's actually a case that came up in our system, and our team did end up flying this patient on both occasions. But on both occasions, very reluctantly, because of the knowledge that this patient really needed to be well palliated. So I think what is a good idea is maybe to go to Michaela. She is one of the practitioners who flew the patient. But what I'd really just like to highlight is that this system, the whole system for this patient, we failed this patient. And this didn't just break sort of your side, and I think your side have been seeing this patient for a much longer period of time. But this case really did a lot of damage, sort of in the Tanin space. It's really hurt our crew. It's hurt our flight desk. It's hurt our system. We've had multiple debriefs with lots of tears. And I'm glad that it came up in this presentation because we set the date for this presentation long before the patient. But the way that this case was handled and how the system essentially at every point there was this attempt to palliate this child, and just the inability and the inexperience and the not being comfortable with this kid in the ascending facility meant that the kid was treated and probably should not have been. He should have been palliated. We were all on the same page.
Yeah.
But the anxiety and at the coalface to make the decision of let's stop life-saving care and let's start really good comfort care wasn't a reality that happened. So I'm going to jump to Michaela because she'll give us some really
Sorry, Gad, I think if you don't mind, just exactly what you said. I think the point here, and thank you for highlighting that because I wasn't sure if it was your service, was the amount of people that this has affected is actually significant, and can it influence further treatment in a negative way as opposed to a positive way? And kudos to you guys for the amount of debriefs that you have, but many people don't have any of that.
Yeah.
And that's exactly your point is kind of exactly where I was going, was the amount of damage that this has done, not only to the child, not only to the family, but to everybody else is significant, and that's never highlighted. So thank you for bringing it out in that way.
Thank you for bringing it up, Dave. I think it's a really important point. I am going to go to Michaela because I see she did put her hand up, and then we'll go back into the next layer of conversation.
Hello, everyone. Hello, Dr. Kluk and everyone. Yeah, so when the patient was brought halfway and already in Polokwane when we've got the patient. And my partner and I stepped into the ambulance and we said, why are we transporting this patient? Also, the family hadn't seen the patient. So The patient was already on max inotropes, urine output was 0 and looked like blood. He was burnt terribly, his eyelids were inverted. And so we then had many calls and decided, okay, we're not going to transfer this patient. But then also the receiving had said, the way you painting the picture, because the referring thought it was 60, but when we looked at it, we estimated 80 with inhalation. So that's quite subjective. Then when the receiving said, okay, don't bring this patient, then we were stuck in the middle of Polokwane with nowhere to take the patient. The referring didn't want the patient back because they felt that the patient had to go somewhere that could manage for definitive care, was what they were saying. So yeah, for an EMS provider, it's hard when you get stuck and you feel alone because now you have nowhere to take the patient. We knew the patient needed palliation, but it also wasn't the right environment as the family hadn't seen the patient. So we did then put the patient's mother on the phone just in case something did happen to speak to her son. But yeah, eventually when the referring did take the patient back, they were on a complete different page. So I don't know how we can fix that in the future, maybe including the referring or maybe the trauma surgeon can speak to the referring and say, look, this is the prognosis. And now, yeah, the family had to be dragged all the way to Joburg. It's definitely dug up a lot of wounds for everyone directly involved in it.
I think we're going to go to Morena, and then I see there's some more hands again in the bigger group.
I just want to say something a little bit off this topic now, but it's based on what Dave said in one of the things he was saying was about, you know, when we don't have the full picture and we don't have the full diagnosis. And so the comment I'm going to make, that whole principle is a whole different big discussion that we don't have time for today. But I just want to say that from our side, from the EMS perspective side, we just need to be, I want to say from a practitioner side, because it's really comes down to the person standing next to the patient's bed. Unstable for transfer and patient for palliative care is not the same thing. And we just need to be careful that we don't become, and maybe this also comes a little bit off the back of sitting in the consultation space when people phone you for advice and you present the patient how you want that person on the other side to perceive that patient sometimes. And if you're sort of, because you are scared and the patient is unstable and sick and whatever, and it more sits in your fear of transporting this patient than what it sits in the patient's ultimate outcome. I think it's just important for us to remember when we start of thinking of having palliative conversations and who we phone and how we present this patient to the person that we phone is it really that the outcome is one that sits in palliative care, or is it that right now we may be not the right person for the transfer, we need more help, or we need to ask, can ECMO come to this baby? Can a septostomy come to this baby? Can, you know, so yeah, I don't want to go too long on that tangent. I just want to make that knot in the back of your mind to make sure when you start the conversation, what is your intentions? Does the problem more sit in your space, your knowledge or equipment or availability, or does it really sit in the patient's true palliative need, poor outcome situation?
Oh, that's such a good question, and it really forces us to look inward and sort of figure out our intentions and our fears and where we lack in our abilities to step in for a patient. I'm going to go to Mike. Sorry, Mike, you should be able to unmute. It seems like there's some challenges. Mike, I'm going to ask you just to exit and then join again, and then it should be able to work. Be good. Oh, there we go.
Oh, there we go. Can you hear me now?
Yes.
Wunderbar. Morning, everybody. Yeah, so my comment kind of starts off with Gilbert's earlier, and then I'm going to follow through on a bit of what Dave had to say. So let me just dig my notes up. I've been filling away a bit. Yeah, firstly, you You can't go rock up at a case and think, well, we're going to have one plan of action. You've got to arrive with various options that you have to think of and you have to consider before you get there. You can't find yourself locked down into this is the way it's going to go and only that way. If you do that, you're going to find it very difficult to transition between a clinical intervention and a palliative treatment. And then also looking at this case you've been discussing and on Dave's commentary as well, it's a bit distressing to look and see how there was clearly no continuity of communication, no continuity of plan of action between the various teams, almost as if each shift changed and now the next group has got another plan. There was no, or didn't appear to be any handover saying this was our decision and this is how we got here. So there was no understanding for the next team coming in as to why we were at that point or why we weren't at another point. That I think could have made a big difference, and also maybe to highlight in cases like that for the transport services. The most dangerous thing you can do here, realizing the complexity of this case and the potential of the palliative involvement and the value it's going to add, the worst thing you can do is do a horizontal escalation. You cannot be discussing this case only with peers. You need to be discussing this up the line with the receiving physicians, with the referring physicians, and everybody needs to be part of the decision-making process in terms of the clinical pathway that's going to be followed. And it's essential to get everybody talking the same language. For me, in terms of a decision point of where a case would go, an adage that served me well is, are we prolonging life or are we merely postponing death? And there's a distinct difference between the two. Prolonging life means there's a quality of life, means there's a value add for the patient, for their family, for their support structure. There's value to that person's continued existence. They add value to the world around them, and the world around them adds value to them. And that can include a patient with traumatic brain injury, with Down syndrome, with a disability, with a mutation. The value that they can add, just because they're different, doesn't mean they need to be excluded. And one must be very, very cautious not to slot patients into a box and go, well, we're going to sideline that for whatever reason. Prolonging of death is a very different thing, and all one is doing there is prolonging the pain, prolonging the suffering, prolonging the burden for the patient and for the family and friends and all involved. And as you've attested to, for the teams that are actually involved in the treatment and care of that case, the emotional burden that gets passed on to the clinical teams is horribly underestimated. And one needs to add cognizance to that and start questioning, is this worth doing? Is this the right thing to do? Are we adding value? Is the patient going to add value to the community and the community to them? Or are we just making the inevitable happen maybe 15 minutes or a day or 3 later? In which case, we're not adding any value at all, and then we're going down the wrong road. Thanks.
Thanks, Mike. We're going to go to Elmi. I think she has a comment on what's been said.
Thanks, Caleb. 2 things. I think a lot of the people have been saying, Lynn said this and Lynn said that, and although Lynn and I are in complete agreement about what we're saying, it was actually me saying most of the things. I was telling Lynn now, if people say you said this, it was me that said it, but you know, it's just a sideline. I think my comment that I want to raise, and I don't want to open a whole can of worms again, but it speaks to one of the misconceptions that a lot of people have about palliative care, and the past couple of comments have spoken to this, where it's either the one or the other, and the ideal situation is that they should both occur at the same time. So it doesn't have to come down to a point where now we have done all of A, so we are moving to B. And if you read about palliative care principles, that's the one thing that stands out. It starts at diagnosis because it's difficult for the parents. And I've had referrals like this where the referral comes in too late, and it feels for the parents that they're being bumped off to someone who is now going to help their child die. And you, as the palliative care provider, become the physical representation of the thing that they hate, namely, my child is going to die. So the whole idea, I think, is to start having those discussions earlier, before all of A has been depleted and only B is left. But that's now, like I say, it's a whole different conversation. And it also goes back to training, where, if you have to institute palliative care, but you don't know how to do it, then you won't be able to do it. And then my last comment would be, is maybe a good starting point after this discussion would be to create somewhat a network where the EMS people can actually reach palliative people, and it can also in practice stop being a us and them situation, but we can just take hands. And if you're in a situation where it's really difficult, you have someone to reach out to with skills that you lack. Because with the counseling of the parents and the families, I found that once they understand the other side of the coin, they buy into it much easier. But you need someone in your team. So maybe just looking into somehow creating a network like that. Even if that's what comes out of the discussion today, I think it would have been a very fruitful discussion.
Thank you so much, Almi. I think that's definitely, it's on the list of what next. So what I wanted to do before we end up or finish up is maybe just run through the panel for some closing thoughts, anything that you think we haven't said or needs to be said, and then maybe just one thing that you think would be the next step. How do we go from where we are now to a system of a little bit better integration? What does education look like? How do we do that? How do we get access? How do we create access for the EMS teams so that we're speaking the same language? Maybe I won't call names, but anyone who is keen or has something burning in the panel.
I can start.
Go ahead.
I just wanted to say two things. So the first is, I think at the end of the day, it's communication is one of the big things that's been emphasized between referring, between the retrieval, and between the accepting teams, instead of it being this disjointed conversation. And then just something from myself, like when you guys were talking about that burns patient, and then the referring hospital refused to take the child back. I know as a junior doctor that feeling of like relief when the patient left. And I think at the end of the day, it's really just fear, because people fear what they don't know. And it's one of the reasons why I decided to go and do the diploma in palliative care, is because I knew I needed to be better at these dying conversations and managing dying patients. Because in the end, the ultimate goal would be that everybody has the capacity to do basic palliative care. And if you're empathetic and you've got the right conversations, and you have morphine at your availability, which most hospitals should have, we should be able to all give a decent level of palliative care. So just speaking to the education part of it, that's one of the biggest things, is trying to get access to teaching and education, and it's taking a long time to get palliative care training into medical schools, and I'm not sure what it's like for EMS. But just as an aside, there are patch courses. Sorry, I'm punting patch now, but there's a patch website that offers courses, and you pay individually for each course. They are absolutely incredible courses, but there's an introduction to palliative care course, which is free, that anybody can do. So if anybody wants to just do the basics, start there. And then if you feel like something else interests you, there's ones on communication and all sorts of things. So that's a good place to start, is maybe to encourage everyone to do the introduction to pediatric palliative care on the patch website, which is free. But thank you for a really wonderful discussion. I've found it very enlightening myself. And I have to say that, I think it's important to work on the relationships. We are very fortunate that one of the people in our EMS in our area is incredible, and he calls us directly, and we feel like we are developing good relationships. So my hope is that, eventually everybody can get there.
Amazing. Thank you so much for joining today.
Thanks. Can I just... I'm going to quickly pop. So I've put the link to the Patch SA website, and it's called the Patch Academy. So you can go and have a look at their website for the courses that Nikki's mentioned. And I think, just to reiterate, I don't think we can wait to get our education systems up to date and up to speed. The world is moving faster than the bureaucratic organizations that we come from. So we have to take the responsibility ourselves to upskill ourselves on our communication skills, but also on our knowledge around palliative care. And I've just also really enjoyed today and learned a lot. So thank you for having me on the panel.
Thank you so much for joining. Don't feel like this is going to be the end of the conversation. We'll reach out and maybe do some targeted learning sessions on this platform as we go forward, if you guys are keen. Miss Cindy, your hand is up, and then Caleb.
Good day, everyone. First, I just want to say thank you for the topic. And secondly, thank you to all the speakers that were there. I feel a lot better now with regards to palliative care. It has always been something that on the comments for presentation, I would say, can we talk about palliative care? Thank you for listening, Caleb. I will start by sharing a story, just briefly. Recently had a case of palliative care, but we spent 3 hours at the transferring hospital trying to stabilize, to move the patient. At stabilization or at vitals and hemodynamic state that we committed that we're going to move the patient, the transferring consultant, talking to the referring doctor, he said, no, the patient should be for palliative care. But from our side, we said, we've done so much for the patient. We'd like to move the patient over because we're comfortable with it. And on follow-up, that patient only lasted, I think, for 8 hours at the receiving and was declared. So in the 8 hours, I think about 5 hours of those was the management trying to see if they can improve. And then 3 hours was literally palliative care. So the patient did end up where the referring consultant said, but then again, to us, it felt like we were failing the patient because we have done so much to help them. But then again, we sort of like giving up on them, and I will use the words giving a benefit of a doubt. But then obviously with that referring consultant, it was probably more of experience reviewing more of the case. But to us, it was a bit difficult to say, let's go straight to palliative care, because there were no like obvious signs to say patient is not improving with the emergency medicine that you're providing. Then we're more likely to go to palliative care if whatever we did is not working. But in our case, it was working, but then with the poor prognosis and what the patient went through, patient was basically for palliative even before we even got to bedside. But then to us, you have that sense of I'm maybe failing the patient, or like the previous speaker, I'm the one who's going to tell the family that their child is not going to make it. And I'm doing that without doing anything. Like I'm the one who didn't do their ultimate best to help the patient according to the family, because I go there and told them, no, your child is going to die. So it becomes a bit difficult to deal with that. But from the presentation, I've picked up some points that I will try and apply, obviously with support from clinical. And in the setting that we operate in, Zyclose here in Polokwane, it's not a comfortable topic, more especially to more junior staff when you go there and say, they tell you need to move the patient, but then you tell them, what do you think about palliative care? What's the prognosis? What's this? What's that? And the system has got holes such that if there is a list to say, I've gone through this, I can consider palliative care, probably only 20% of stuff has been done to make like a proper clinical decision. So yeah, thank you very much. I don't know if that's a question or a comment, but that's what I had to say. Thank you.
Thanks, Masindi. I think we'll go to Caleb, and then just some closing thoughts from the rest of the panel.
Thanks, Caleb. Yeah, just a closing thought from my side is I think it is important for all EMS providers to upskill themselves in at least the basics of palliative care principles. And the reason for that is because it will make us better paramedics. It won't just improve our abilities and skills within palliative situations. It will improve your ability to be an EMS care provider at the scene of an MVA. And just a simple example of that is, for example, we've spoken now about comfort care being a part of palliative medicine, and that's very true. Is it not our goal within the EMS to make all of our patients comfortable, whether they are palliative in nature or not? I think it should be. I think it is. And so there's something there that we can learn from palliative care, not just for the sake of palliative care, but to make ourselves better healthcare providers in general. And that will help us in both emergency and palliative situations.
Yeah, such a powerful point. And I think super valid. All of our patients should be comfortable, however we can get that right. Just to go around the room, I think Julia's finished off. Lynn and Almi, do you guys have anything that you want to add at the end here?
Lynn? I think from my point of view, it's just really reiterating, like you've all said, is the training and to empower yourselves. Because once we have that tool in our toolkit, we'll feel far more comfortable about talking about palliative care. And just change our mindsets. And it may not be a bad point for those who are in training to speak about adding the palliative care to the curricula. And you make a really powerful point with your different cases that you've had. So I think it's time that that discussion was had, that we're not all just go, save a life, but that we're thinking about quality of care for our patient. Thanks.
I completely agree, Almi. And on the previous comment as well, I often, because I do see adults as well, and I often tell the families, for your loved one, maybe the thing that will cause their death now has a name. For you and for me, our cause of death does not yet have a name. But just because we know now that it's coming, we are more intentional with how we are living. And isn't that the way we should be living in anyway? Should we have to wait for this time of life before we start living intentionally like that? And what you said about, isn't that how we should be treating all our patients? If they are curative, if they are palliative, they all deserve that kindness and that dignity. So I like that comment. And I think I've spoken enough in the rest of the talk. So thank you for a very insightful talk. Thank you for inviting us to be part of it. I hope it added some value in some other way for the people who were listening. And have a lovely day.
Thank you so much to all of our panel for giving up nearly 2 hours of their very busy days and probably time with patients to share experiences and thoughts and knowledge with the bigger team. I don't think this will be the end of the conversation. I think there's a lot still that we probably need to try and fit into this year, and to try and make some resources available as widely as possible to as big an audience as possible to make our practice better. Please don't forget to complete the register. Register has been sent in the chat. Please do not load your data to the chat. It will not be counted for CPD points. It's really difficult for us to follow up when there's 400 people popping their stuff into the notes. So please make sure that you complete the register. And then thank you just to the bigger audience for your amazing interaction today. This is exactly how Coffee and Cases was designed, and is the intention in getting as many people together, sharing experiences and thought processes as possible. The word of the day will be good death. Please make sure that both of them end up as well as your HPCSA number correctly in the register. If there is anyone who didn't get a chance to ask questions or think about things that they would like to share, please don't feel shy to put it into a message, and we'll happily use it to inform some of the sessions that are coming up in the future. Register link has been shared a few times in the chat. Please just make sure that you can see it in the chat, and then have the most amazing day.